Today I'd like to share new insights of Dmac. This is my financial disclosure. There are two main advantages in Dmac. One is an excellent visual outcome. The other is an extremely low graft rejection. This is the actual outcome from my patient, who received Dmac in one eye and DSEK in the other eye. As you can see, Dmac is excellent compared to DSEK. From Asia, it has been shown that Dmac has a longer survival time than DSEK or PKP. Before starting Dmac in Japan in 2014, I visited Germany, where I watched Dmac by Professor Kuz, Dr. Bachmann, and Dr. Tudas. However, mastering Dmac in Japan was quite challenging because the situation here was quite different from Europe or the US. This is a study by Professor Shimazaki in 2007. This is the proportion of bullous keratopathy in Japan. Most of them are pseudophakic bullous keratopathy, which means endothelial dysfunction after complex cataract surgery or shallow anterior chamber, as you may know, which is laser-induced. After overcoming a steep learning curve, I can perform satisfactory Dmac surgery without complications such as graft rejection or upside-down fixation. I like to share my patient of Fuchs endothelial dystrophy with a history of pulse vitrectomy for retinal detachment. Now you can see, using air infusion system from vitrectomy machine is very easy to perform desmetorexis using slit knife 2.8 mm incision using pressed ripple tissue with S. Graft is carefully prepared from the donor. Now I'm going to stain Dmac graft with brilliant blue G for 1 minute. Using IOL injector, I'm going to inject Dmac graft very carefully with the help of OVD. I'm washing OVD by BSS and checking the correct orientation. I'm unfolding Dmac graft by Rizama technique. Now checking the correct orientation. So I like to inject small air bubble. From now, I'm checking the correct orientation and attachment using OCT. Now I'm unfolding the peripheral limb by tapping and adding 20% SF6 gas. Finished. Also, during my training of DMEK, I could develop some techniques and publish papers. For example, I developed a special technique with Dr. Kobayashi called the double bubble technique, but he has recently shifted to his holding technique. However, every technique itself will fade away, and science is forever. It's more important to address the new findings of DMEK compared to surgical techniques. Let me give an example. As you can see, it seems like two eyes are quite similar in terms of transparency or visual outcome. However, careful evaluation allows us to find out some pathological changes in DMEK eyes, such as iris change, macular edema, corneal thinning. These are the topics I'll talk about today. First, we found out extremely thin cornea after DMEK compared to healthy normal cornea. The reason for the phenomenon is unknown. This disparity of corneal thickness between peripheral area and central area might be a reason for residual high-order aberrations in DMEK. Also, we found a change of volume of cornea or anterior chamber after surgery. The corneal thinning after surgery resulted in the increase in anterior chamber volume. This is a surprising result, but you may know the phenomenon. We found a higher incidence of iris synechia after DMEK, especially in small eyes. Most of our cohorts were PBK with small eyes. This problem is related to inflammation, I think. Next, I'll talk about immune reactions after DMEK. Another issue is the higher incidence of CME, cystoid macular edema. We found a 13.8% incidence of CME after DMEK. CME was correlated with iris damage. This phenomenon should also be related to the inflammation, I think. This is a study that I did in Germany using German data. DMEK had a positive impact on the corneal neovascularization. This is the time course of nerve regeneration after DMEK. The nerve density pre-op was quite low. However, there was a significant increase post-op over the time. This phenomenon could be explained by the reduced inflammation after surgery. This is our important study. We found a significant decrease in cytokine profiles after DMEK, increase in neovascularization or decrease in corneal nerve can be explained by the inflammation or inflammatory cytokines. It is possible that healthy endothelium has an important role to suppress inflammation in the anterior chamber or ocular surface. This is a summary of our findings. Before DMEK, there are some issues to address. We can find a significantly higher level of cytokines in the AC and thick cornea with neovascularization due to the endothelial dysfunction. After DMEK, functional endothelium reduces the corneal thickness. The healthy endothelium has a capacity to reduce the inflammation in the AC, which results in regression of neovascularization and nerve regeneration. Some anatomical changes with optical quality can be explained by corneal thinning. However, DMEK eyes have a little bit higher level of inflammation compared to normal eyes, which results in iris synechia, cystoid macular edema, and higher endothelial cell loss. Last topic is the application of artificial intelligence in anterior segment surgery. We try to use AI to the need for rebubbling after surgery. However, the AUC was over 0.95, which means the AI made it possible to predict the need for rebubbling after DMEK. This is a summary of my presentation today. Visual outcome after DMEK is much better than DSEK. Some prominent anatomical changes were found: iris synechia, thin cornea, or CME. The inflammation after surgery might be correlated with abnormal iris or CME. DMEK might have an immune suppressive effect. The use of artificial intelligence should be very useful for our work as a corneal surgeon. There are many topics to disclose. Thank you for your attention. See you at the next conference.